Well, thank you very much, ladies and gentlemen. Thank you for joining us. This panel is from Code to Care, the AI healthcare evolution. My name is Dr. Roland Illing, and I'm the Chief Medical Officer and Director for Global Healthcare and Nonprofits at AWS. I'm also an academic interventional radiologist and still faculty at University College London, where I was doing a lot of research around image-guided intervention and new methods of treatment, and spent some time in Europe as a Chief Medical Officer of the largest imaging and intervention group in Europe that mainly focused on radiology and cancer care. And that was really where my first introduction to platforms of care and AI took place back in around 2015. I'm delighted to be able to moderate this panel today with a really esteemed group of experts who will be able to share their unique insights into this space of AI in healthcare, which I think we can all agree is the hot topic of the moment. Everyone is talking about AI in healthcare, in particular generative AI in healthcare. And so you can see their titles on the screen. I'll ask each of them in turn to just give a little bit of background and position themselves. But I'm delighted, we've got a very diverse panel. We've got experts on healthcare policy and governance. We have experts on AI implementation in the real world and direct care, and also the cutting edge of technology. So I look forward to a really interesting conversation. If we have time at the end, we could take some questions as well from the audience, but I know it'll be a very interesting conversation. I'd also like to thank Russ Lipari, the CEO of Health Connect South, for the kind invitation to speak and the amazing environment in which it's put on. And I hope that we can keep you distracted from the beluga whales, because they are amazing. So it's going to be a discussion in three parts around governance, what we're doing today, and technology in the future. And so we're going to start off with really about governance and responsible AI. We're hearing a lot today about responsible AI. How can we think about that? What's being done? And so I'd like to first of all turn over to Dr. Sandra Ford, who I'll let Sandra introduce herself and her background and her take on where AI governance and regulation is going. So maybe Sandra would like to take us away.
Thank you. Good morning, everyone. Sandra Elizabeth Ford. I'm by training a board-certified pediatrician, but recently left the White House and the Domestic Policy Council, where my focus was health equity. And when you think about AI, you really need to be thoughtful about health equity. There's three things that worry me: privacy, security, and bias. The data that is used in instances to move AI forward can have inherited bias. There's a lot of clinical trials that did not include diverse populations, and so if that's the data that you're basing your AI on, it can be very dangerous. So that's why we are starting to pull away from race-based algorithms, because we know that these things are not always accurate. I can give you a quick example. There is a pediatric renal function AI in terms of UTIs, and there are points given for race or not given. So there is, if you are non-black, you get points. If you are black, you get no points. The intent was to avoid unnecessary catheterizations in children, but what happened is they were overlooking a lot of UTIs because they were not including the racial, they were excluding blacks from the study. And so sometimes we are intending to be helpful with AI, but when we are not thoughtful about how we are looking at populations, it can be very dangerous. Also, social determinants of health have a huge impact, and we may or may not be collecting that type of data, because I can put you in a trial, but if you are not nutritionally sound, or if your housing is unstable, that impacts how you function in the trial. So we just need to be thoughtful, and as we move forward, think about how to make these better.
Absolutely. There's an analogy of garbage in, garbage out.
Yes.
When we come to this thing. Khan, you're at the forefront of AI development. Maybe just could you put yourself in context about what you've done and your view on responsible AI and how you're developing it today?
Absolutely. Thank you. It's great to be here. And first time having Wales as the audience is pretty interesting. I'm also like Roland, a radiologist, but my academic career at University of Maryland Hopkins was on computer vision, machine learning, and AI. Started like in 2003. So I've been doing this for more than 2 decades. Spent time in Microsoft, started their first healthcare AI team, and now founder CEO of Hopper, which is bringing generative AI and medical imaging in practice. I think the issue is, you can train data from a research point of view, but we as humans are, I don't know if this is a controversial thing here, but we are biased. So human bias, even if you're using real world data to train, which is what we are doing, there is bias that moves into the model. So how do you understand? So our opinion is that the way we approach is we look for the bias before data goes in to any kind of model training. How do we understand? And some of the academic partnerships that we've done is really to understand those bias in those data before we start training the model. And then how do you actually test those biases in the models, especially in medical imaging? So is the medical imaging AI algorithm or model predicting different outcomes of different diagnoses based on the race ethnicity of the patient? There's a famous study that was published by folks here at Emory, Dr. Judy Gaucher, in which they can predict with 99.6% accuracy race on just looking at images, nothing else, right? On X-rays, CTs, and MRs. So, and we don't know what those features are in those images that is having model predict a race of a patient. So the model itself, just looking at pixel data, is able to identify what the race information is. And how is that contributing to models learning of other features in images? We still don't understand. So I think the idea of explainable AI and understanding what these biases are, understanding what these limitations are so important, and being able to challenge ourselves to make sure we're addressing it, at least making people aware that we are finding this in our models. So when you are making clinical decisions, make sure you're thinking about these things which we already know the models are doing or not doing.
I think that's a really good point. And interestingly, AI has been in the world of radiology for a very long time. So in AWS, AI has been used for the last 20 years. Certainly, it's been going on that long in radiology as well. So it's not new. However, I think the way that AI is being delivered is new in terms of moving from narrow AI, so training to answer a question on a specific data set with a specific answer. And these kind of algorithms typically don't change or evolve unless they are rewritten. And so they're pretty predictable once they're out there, to the new generative AI where the results may not be as predictable. You can answer a much broader spectrum of questions. There was a very interesting article published in the Harvard Business Review from the 4th of September, so very recently, a couple of weeks ago, by David Blumenthal and Bakul Patel, that argued that generative AI should really be treated more like a physician than a medical device. So the FDA has already cleared almost 1,000 medical devices with AI in it already that are in clinical production. So you can use them today. But when it comes to generative AI, because there is a component which evolves and learns, they are proposing a new way of considering it in the same way that doctors learn as they progress. From medical school, you leave and you're certified, but you have to be revalidated as time goes on. And often, 20 years later, it doesn't really matter where you went to medical school or who taught you or what books you read. It's actually how current you are and how accurate you are to the audience you are or the patient population you are currently treating. And I think that's quite an interesting concept to think about it actually as you would evaluate a doctor. So, Melek, I'm interested from the clinical perspective because you are both within a health tech organization that's a spin out of a clinical organization and still within the clinical organization. How do you view that? How do you manage that bit of governance?
Yeah. Welcome, morning, everyone, and welcome to the Belugas today. My name is Melek Soma. I'm Vice President and Chief Technology of Radiant Health and ThedaCare healthcare system in southeastern Wisconsin. I'm also an assistant professor of medicine in clinical and biomedical informatics. The way we look at responsible AI, at least from within our organization, is we look at it from a patient perspective, which means our value is to deliver the right care to the patient that is safe, equitable, and evidence-based. So if we look at that's actually our responsibility as clinicians, as a healthcare system, actually I see AI in two ways. We actually have a responsibility of actually delivering the value of AI if there is a value there. So I actually take it from an optimistic perspective where if we as a healthcare system believe that AI can deliver and improve our quality of care, we have to make that investment and we need to be part of that journey. And that's kind of a very important topic, and that leads us to not only be actually on the receiving side, but actually engaging, because we have a responsibility to our patients. We need to be the voice for our patients and for our clinicians to deliver on the promise of AI. It cannot only be a technology piece, it's a social, technical implementation of it. And if that means we're changing what's the narrative and what's the definition of a clinician, that's actually the role. I mean, one of my former mentor, the late Warner Slack, actually had a very famous quote. Every doctor who deserves to be replaced by a computer should be replaced by a computer. And that's a very important topic, because it's actually not to maintain who we are, it's actually to deliver the value that we have to give. But on the other side also, being responsible on the AI is not only being an investor of building it and contributing to it, but also being careful about its implementation. And that's also very important. So we need to also not be afraid of doing it, but we need to also invest in building the technology and the framework and the ecosystem around it to make it safe and equitable. And those questions that are raised by the audience today and by colleagues here are very important. Bias exists everywhere. I mean, to add another example of bias, there was a very famous research done by Ziad Obermeyer and group at University of Chicago when they looked at insurance systems using an AI model and a very simple ML model, actually, to look at who deserves to actually escalate care so they can get a very special care team receiving and improving the care quality of their patients based on utilization. And the idea was very simple, was if someone's need more care, what if we actually get upfront and provide them much better preventive care services? And the team used the model, found out that actually the model was discriminating more African American Black than actually white, because it was using the cost of delivering care services as a surrogate for saying this individual need more care. And what they missed is actually people don't have access to care if they need it. So using cost as a surrogate for who needs care at the front was actually wrong. So bias is very everywhere, and that's kind of where I think we need to be careful about.
You mentioned frameworks a second ago. So just dive a little bit deeper into the framework. How are you thinking about frameworks in the context of this?
Yeah, one of the ideas is, as a healthcare system, we need to evolve our technology stack and our technology capabilities. We've been spending the last decade building an electronic medical record system. 15 years ago, I think 6% of hospitals had an electronic healthcare systems. Today, most of healthcare systems have a technology component, but it's actually just one fraction of the entire story. Like, we need to contribute data that is unbiased. We need to build a model to train. We need to the idea of having AI as a resident. We need to build a model to train, to confirm, validate, and revalidate things. And this technology needs to be built. And I think ARPA-H, I'm not sure if there are colleagues from ARPA-H here and others that are actually contributing to that movement and helping really leapfrog our ecosystem to build that technology.
Perfect. Sandra, you had a point.
You know, I want to go back to your evidence-based medicine conversation or comment, because that's sort of part of the problem, is the evidence that started the AI may not be sound. We have a history of underrepresentation of certain populations in the evidence, and so that if that's what you're basing your AI on, you're already starting from a field of bias. And so that's why, similar to training, we get evaluated. I think that AI needs to have bias audits frequently to make sure that what we're telling it to do is actually appropriate. So I always, when I hear evidence-based medicine, the evidence may not be sound. So
perfect. Come.
So let me give you an example of bias that is not nefarious or intentional, but more of what you're talking about, right? So we built a model to see likelihood prediction of somebody coming in with respiratory symptoms, likelihood of death as somebody arrives in the ER. So, based on patient arrival, based on nurse triage, can a model predict the likelihood of the patient's dying from that aspect of it? And what we found was the model was predicting that if you have asthma and you show up in the ER, you're actually more likely to survive. So not to do aggressive treatment, which was weird. Like, we didn't understand why would it do that, because we all know that if you arrive with asthma and you get pneumonia on top of it, likelihood of having comorbidity is pretty high. we found out was that in the underlying data, when a patient came and said, I have a history of asthma and they have pneumonia, they were immediately being sent to the ICU. And they were surviving because the aggressive treatment was happening. It was actually the correct thing that was being happening, but the way model was trained, model thought that AI is actually, the asthma actually is a predictor of survival, not a predictor of severity of pneumonia disease that's going to happen. So you need to understand what your current practice patterns are. The other thing is that happens because of these practice patterns shift, right? I mean, 5 years ago, you didn't have weight loss medication. All the data used 5 years ago is coming in, have no understanding of the impact of that to a patient's condition or whatever it is happening. So what will that impact create? We don't even know yet, right? We don't have enough data in the models to train to understand what these new medications, new therapies, new treatments are doing. I mean, we didn't do thrombectomy strokes aggressively in the past. Now we do. I mean, a lot of these practice changes and that change underlying data. So we have to really understand what are we using the model for, what it's trying to predict, and how has practice pattern changed the last 2 years, which may not be in the data that model was trained on.
I think that's a really interesting point, because the pace of change, both in healthcare delivery and in the technology which underpins it, are both changing really, really quickly. So to stay ahead of it and to keep up to date is a real challenge, especially, I think, for frontline care providers whose job is to deliver care. To try and keep up with the tremendous technology change that's taking place underneath is very, very challenging. I think an interesting piece on the governance side is also about level of risk, because obviously AI can affect every point in a patient journey, from identifying even people before they become sick, all the way through to the end and treatment and recovery. But not all interventions or not all parts of the pathway carry the same level of risk. So there's certainly something that we're approaching in AWS, which is about having a risk-based approach for AI. So maybe a scheduling AI is not quite the same risk as a clinical decision support AI. So how can we group that AI in terms of the numbers of barriers to entry and the regulatory framework around it? Because obviously the things that impact direct patient care and outcome have to be very highly regulated. But those that may be to do with scheduling or operational or bed management may not require such intense scrutiny. So I think there are levels that can be approached. And it's also about outcome. So again, it's interesting. So the paper in Harvard Business Review said that, do we need to think about all of the data and the training and worry about the bias so much if you're focused upon the outcomes? Because if the outcomes are not correct, there is something wrong upstream, essentially. So obviously transparency, availability of correct data sets is absolutely essential, but it's really about outcomes-based that is the real focus. And so how we come to there. As I said, AI has been being used throughout healthcare for a long time. So maybe, Melik, do you want to give some examples today of where you're seeing AI being used in clinical practice, just to really give everyone a flavor of how prevalent this is in today's medical practice?
I mean, I will focus more on the generative AI when we see things being implemented today. And the way we see the movement across many healthcare systems is there are probably 3 levels. I think there is the immediate term where we see generative AI being implemented, to your point, within safe environment. And that could be ambient listening, clinical summarization, and actually supporting in-basket messages for providers. And this is more, I would say, a back office implementation more than being at the clinical side. And this is where we see kind of clear benefit, but also a lot of what we do today is around that AI governance to help protect what we do with that. So even the value is minimal, we're actually learning a lot about how to govern our AI implementation, how we look at our data, how we look at the privacy. What does it mean to have an ambient listening tool with our patients and provider? Does it change the behavior being actually listened to? So there is a lot of research being at that element, and we are not looking at value. Honestly, we are looking at really small incremental value, but we actually building the capabilities. And this is where we are most focused on. The second level, I think, of our implementation, and this is where we see more improvement, is actually making investment in building more and contributing to build AI models for clinical care and decision. And one of the initiatives we recently launched, we actually created a new primary care model within our healthcare system that is actually run by an engineering clinical team. So we brought actually an engineering team and clinicians within an organization and say, if we actually redefine what is delivering care services to our patients, and let's remove your clinics and make it digital, what that looks like. And one of the things we built today is really a new asynchronous chat-based communication with our patients, where we actually have AI being embedded and evaluated and followed by clinicians. And the idea here is really to start reimagining what's that actually having AI as a co-pilot for clinicians when they deliver care services and what that means within really a protected kind of environment.
I think that's very interesting because there's a philosophical difference again between generative AI and foundation models and the way that you interact with them. So the chat element or the agent piece in front. And I think this is something that we're going to see more and more of as time goes on. It's the rise of the agentic interface with the foundation models underneath. Because I think in terms of patient and clinician and provider interaction, I think it's the agents that you'll be interacting with rather than the foundation models or the generative AI itself. Is that correct?
Absolutely, absolutely. And the third element that we are very excited about, and this is probably more of our research side, is actually giving patient direct access to our services. And this is where I see the largest benefit, honestly, in the future. I know that, we did a lot of our research, for instance, about digital therapeutics, and what we found was actually patients trust their clinicians, which is great. Like, they actually adhere to treatment more with having a clinician in the loop. They adhere to protocols, and we are able to achieve much better outcomes by actually combining clinical services plus digital. However, what we also found, if we actually provide that self-service to the patient, even though the adherence is lower, actually the scale is 10x the scale that we can achieve with the number of clinicians we have. So there is a benefit here of scale that is going to be super important for us. And if we really want to improve care today, cost and scale are going to be important topics.
I think that's a really important point as well, because the healthcare workforce is just in trouble at the moment. There's too much work to do. There are too few people being trained. Certainly in the UK workforce census for radiology, the amount of cross-sectional imaging, and I'm sure it's very similar for the US as well, the amount of cross-sectional imaging occurring year on year is increasing 10%, whereas the number of radiologists and associated practitioners that can report is increasing around 1% to 2%. So this is just a diverging graph which has to be made up somehow. So I think how we can address exponential problems without just linear solutions, you can't train your way out of this. How do we do that? And I think this is where this comes in. So Sandra, how about you? Where are you seeing AI having the biggest effect, do you think, today?
I think it's a time saver for one. Let me just say, though, there's nothing that replaces human touch and human evaluation. But if you have something that's helping you guide your decisions that makes you move quicker or takes away some of the busy work, then the efficiencies can be life-saving. And particularly in underserved communities, I think that there's a big possibility that could be super helpful. So in terms of moving things forward faster, helping people who decide for themselves in terms of autonomy, do I really need to be in the emergency room, or is this something I can manage on my own, and knowing when to escalate. Now that requires a certain level of health equity and health literacy, because you got to say the right word. If you just put in there, I don't feel well, you may not get what you need. And so there's a learning curve on that side as well.
I think that's fascinating because, again, one really powerful facet of generative AI is its language ability and its ability to take complex language and synthesize it into other languages or to other educational levels. And so I think if you can take, and again, to Malik's point, if you can take, I spend most of my time as a physician translating medical letters my family receive into natural language. I think a role of most doctors in the room probably do that. I think there's a powerful piece here from generative AI to be able to allow accessibility to complex medical conditions, to educational attainment, to different groups. And so there's some very nice work being done in the pediatric space, where there's a group from National Children's in DC that have been working with a group in Kenya with medical education material, translating it into the local languages to enable those care providers to provide access to care to those underserved populations. So I think it's a very elegant use of generative AI to translate those materials. Khan, you had a point.
So you mentioned the divergence that is happening. It's actually worse in the US in a way. So if you look at our aging population, our baby boomers are coming up. That's the population that gets the most imaging. So we have somewhere between 23% or 18% increase in that population, and imaging needs going up. Turnaround, the ER is going up. That's requiring more imaging. Lot more non-invasive stuff's happening that requires more imaging. So in 10 years, we've seen 36% increase in imaging volume in the United States. Can you guess how many number of radiology residency slots we increased in the last 10 years? Anybody guess?
Decrease.
We decreased 15. What happened to reimbursement in the last 15 years? In radiology, it's either gone down or stayed. It's 44% reimbursement decrease in the last 15 years. So this can't be sustainable. There's another 2.9% cut coming in January, and obviously in this year, election year, nobody's going to go change that. So how is that going to impact? I'll tell you my personal story. My wife's a radiologist too. When she started at Loyola in Chicago, there were 12 body imaging radiologists. Today, there are 2. In the meantime, Loyola merged with Trinity Health, so that same department covering 1 hospital, 3 imaging centers, today is covering 3 hospitals, 5 imaging centers. 8 to 2. When she comes home, my kids say, Mom needs an hour to decompress. Nobody should talk to her. That's what is the reality of this today. So we need these tools desperately. The problem is, when these tools are created, you have to think patient first. You have to think that's your first principle. Whoever is building it, developing it, implementing it, deploying it, using it day to day, it has to impact the patient first, then everything flows. Otherwise, it doesn't. So today, as of July, there are 822 AI algorithms or applications approved by FDA for medical imaging. Most of them, what they did wrong was, as a radiologist, Roland would say that, we love looking at images and actually helping patients. Anything else you make us do, we hate. So what do these AI applications do? They start putting things on the screen for you to look at. So it just becomes noise, becomes information overload, and it actually sometimes increases time to interpretation and things like that. 2 months ago, I got a text from faculty at UPenn, one of good friends that I trained with. His text was, today kicked my ass, the worst shift I've ever had. He read 142 CT scans in 1 shift. I never read more than 80 when I practiced, right? Never, ever. And 80 was like, I need 2 days of vacation after that. Do you want to be that 100th patient or 140th patient that he is looking at his scan on? No, you don't, right? So this is crisis. If you look at globally, entire continent of Africa, 1.2 billion people, has less pediatric radiologists than just the Longwood medical area in Boston. Just think about that, right? 1.2 billion people have less pediatric radiologists than 1 block where Brigham Women's and Boston Children's Hospital are, and Bethlehem Deaconess Hospital, right? Anyway, just giving you a perspective of how big this problem is and how big it's getting worse and why there's desperate need for this stuff. So, and then explainability and all this stuff absolutely come into play, but the problem is pretty massive and it's actually increasing.
Well, it's interesting around use of generative AI to train the workforce as well. It's quite interesting. So there's a very, again, interesting paper that was published around generative AI. Because again, when you're trying to train a new resident in a certain area, there are lots of criteria to hit. And so if you're an educator and you're trying to make sure that all of the trainees are trained, you've got to devise certain OSCEs, so they're observable real-world environments, to examine them on. And this is really time-consuming to try and come up with new ideas and new scenarios for students to interact with actors. So there's a very elegant paper published where they're using generative AI to generate scenarios and generate scoring charts to then generate reporting. And then you can use generative AI to actually record the interaction and then extract the meaning from it and then actually provide the score. And so again, I think there are lots of tools here that are low risk to patients, but they're really important in terms of healthcare, in terms of how it's going to be delivered. So I think there's some really interesting pieces here that are potentially low risk, but will have impact.
And I think that's a really great example because it was one of our students who built that model. And it's fascinating because they actually build it out of necessity. We don't have enough clinicians to train, and when they figure it out, they build a model to actually train themselves, and they share it internally. And actually that led to the publication, and they can open source the work. But that's kind of the innovation that we are looking for, and that's kind of what we defined. That it's not only improving, it's really changing even the landscape of how we operate as clinicians as a healthcare system.
So that really goes on to our next, so the future then. So this is where we are at the moment. We've got the regulatory frameworks that we've got. We've got the AI and the machine learning. We've got the start of generative AI coming into clinical practice, because as you say, there are companies like Pieces Technology that do this clinical record summarization in production today. So these are generative AI solutions in production, running on medical records to consolidate the information for handover, for letter writing. You have DeepScribe, that is the ambient listening solution, so that actually captures voice conversations and captures it and puts it into a record. Where are we going, Khan? So again, so you're at the forefront of the development here. Where do you see the future in the next steps?
I'm so optimistic about the future of this. To be honest with you, when I started this work in 2003 and we were in Microsoft in 2012, we thought, it's just going to take off now, but it took a time, right? And we talked about that there's been linear progress in AI. If you look at it, actually, what has been happening, but awareness of it has happened with OpenAI and ChatGPT coming out, and suddenly it looks like something major happened. It did happen, but it was like, it was the iPhone moment for AI that happened, aspect of it. So the other thing that is happening is how fast the models are improving, right? So if you look at whatever products you have AI today, you are using today, I'll give you some perspectives, right? So, and then we can do a thought experiment. They were trained on an NVIDIA GPU called A100. Majority of them were trained on that. Some are coming out that were trained on the Hopper H100 GPUs, but most are 8100 GPUs, right? And the algorithm was transformer-based architecture. The GT in the GPT stands for transformer. So the Blackwell GPU that NVIDIA is coming out with is 40 times more efficient and powerful than A100, right? You can imagine 20% improvements in something. How do you imagine 40 times improvement in something? In December 1st, a new model architecture came out called steady state models. These are the short form they're using is Mamba. That model, the algorithm, takes one function in the transformer and makes it linear rather than quadratic. And what it does is it increases that also by 40% efficient. So there's this new, after the T of transformer, a new kid is in town that is 40 times more efficient as an algorithm. 40 times 40 is 1,600 times efficient. So by this time next year, our model and our GPU have gone 1,600 times more efficient. So now how do you imagine something that's become 1,600 times? So if you look at horse, and we use horse powers, right? From a horse to a plane, what is that improvement? How many times is the horsepower going up, right? You hear cars, supercars, 800 horsepower. That's not 1,600 times. So that's the improvement scale we're talking about that we can't even imagine what that means. So it's really hard to imagine next year. I'm talking about next year. I'm not talking about 10 years from now. What will be when you have that kind of improvement in performance of GPUs and architectures. So it's really exciting to see what comes out of this stuff. We're seeing a lot of amazing applications that are actually making a difference in patient care, making a difference in clinical workflow, and providing that ROI that is needed. So like as Hopper, what we are doing is instead of building a new application, we want to enable all existing applications to be AI-enabled. So our output is an API, meaning somebody else's software can talk to our backend and get AI results back and display however they want to display. So really enhancing.
And that's specifically in imaging, isn't it? That's a foundation model for medical imaging that will be something that other organizations will be able to tap into in the future and leverage the power of the model that you're building.
That is correct.
And then enrich it and be able to use it for other applications. So it itself is a tool which can be leveraged for other purposes. Because again, that's the generality of these foundation models is so interesting. But this is going to be a specific foundation model for medical imaging, correct?
That is correct.
Perfect. Malik, where are you seeing the future going in terms of the generative AI in particular? Where is it going to go to?
I'm actually equally optimistic. I think you got in this panel very optimistic people here, so I don't know if it's going to be a good. I think Sandra hopefully will do some equilibrium here. Or probably optimistic too, so that's great. But I honestly think there are few moments in human history like you have exponential opportunities. And I think we had one exponential opportunity with the transistor, like back in the days, and then we had exponential opportunity with the internet, and now we have like exponential other opportunity with AI. But what is different in the AI is actually the intelligence piece is also exponential. So there is this piece like we're gonna have to deal with it, and we are not as human really good with exponential calculation. Like we don't understand. We only see things in linear. So I think there is a lot, and it's very important for us because it's actually also on a good mission. Like if we are able to really at least improve care, even for 10, 15%, let's say within the next decade, that's a major improvement. And I think that's the value we have. So I'm really optimistic also because even our clinicians, our ecosystem is actually thinking about this from the right perspective. We learned a lot over the last 100 years of how to improve medicine and how to make medicine much better, even evidence-based, even not that great in evidence, but at least we start building that right framework. So I'm optimistic about it. I'm also optimistic about the open source aspect of this work and how the entire ecosystem is really investing in making the right data, collaborating, and making the investment to build it happen. So on my perspective, I think this is going to be great. I think healthcare systems, we as myself, like we must contribute to this and be part of the collaboration, and that we need to maintain the trust of the patient and the trust of our ecosystem. So I'm really thinking like this is going to be an important topic, but it's going to require investment. And it's going to require a lot of work, really building the right framework, as I mentioned, that is not only technology, but also the right framework from a regulatory perspective, from a practice perspective. Because if we increase 16 horsepower, you don't want one who actually was trained to ride a bicycle now driving a Ferrari. Like that doesn't work. So we need to improve that, and that's going to be very important for us to get that training right.
That's great, and I think the exponential point is really important. So again, a lot of you may be asking, why is AWS even involved in this conference? So Amazon Web Services is a cloud technology provider, and so it democratizes access to computing power, storage, networking, and AI capability to developers around the world. And so you don't need to be in an ivory tower and invest in large amounts of computing power yourself in order to do experiments. You can tap into infrastructure as needed, and it can scale up and scale down. And so we're seeing hundreds of thousands of users of AI on using our global capacity of data centers, really driving at this question. And so how can we also help in this in order to provide the capacity to allow this exponential transformation to take place? Because a lot of this AI that we're talking about, the foundational models that are being built, require cloud computing and the infrastructure from these cloud providers in order to deliver the results they're getting, because they require such massive compute workloads. And large amounts of data also to be managed, because managing the data, the underlying data, is also incredibly challenging to hospital systems. It's not hospital systems' bread and butter business to manage large data centers. So we're seeing a massive shift in real time at the moment to running production systems in the cloud, where data can then be unified, accessed, and be put to work. So again, I think that for context is really important, that a lot of the information, a lot of the technology here is underpinned by cloud computing services. Now, obviously, in the future, there's also going to be regulatory changes. So I'll be interested, Sandra, where are you seeing the regulations going with regards to this, especially when considering generative AI?
Sure. So AI in general, over the next 5 years, the strength of it's going to increase 32 times. Over the next 10 years, 1,000 times. I think of AI as a water hose that's on high, and you have to be very careful that you have control of it. What we're going to see in the very immediate future, HHS has already created a rule that prohibits discrimination in clinical-based decision tools, but it's optional. It's voluntary at this point, and so some will adhere, some will not. We've already had emphasis at NIH and other institutions on trying to make sure that clinical trials are more diverse. We need to make sure that the people who are programming AI understand diversity, that pool representation matters. So we want to make sure that our trainers are diverse, as diverse as the population that they're going to be treating. I think that the CMS regs that now require social determinants of health questions to be asked of Medicaid patients, I'm looking forward to when that data is incorporated into AI, because that's powerful. If I can find out that not only do you have cancer, but you have some housing issues, you may be living in an unsafe environment, you have multiple children, or you're lacking health literacy, that really gives you a comprehensive ability to care for someone and not just prescribe them medicine. And so that's what I'm looking forward to, is when we are thoughtful about regulating things in a way that allows us to think of a patient holistically, and make sure that the folks that are training and that we're assessing these tools to make sure that they are appropriate, and the people that are training them know that they need to be evaluated periodically as well.
Yeah, and I think, as we've said, I think there are robust policies already in place to govern AI. I mean, the FDA has already got robust policies there. I guess the question is where the gaps are, and I guess it's plugging those gaps without reproducing new regulations on top that duplicate existing regulations and therefore cause confusion about what to follow. The international regulations are also interesting because AI and generative AI is not just a country-specific sport. These algorithms are being built all around the world, and so it's interesting. The first ISO release as an international standard has been released around AI, which is a 42001. And so that is now a standard which AWS is certainly following, and we've just joined the Coalition for Health AI. So there are a number of groups being stood up to look at regulatory frameworks in the future to make sure we're all being compliant. So do you think that we're going to see more of these frameworks being developed and standards bodies being set up to address it?
Oh, absolutely. Britain was way ahead of the mark in terms of social media monitoring. And then the US is now starting to catch up. But these are powerful things, and we don't really understand the impact so we didn't have this growing up, and so we're seeing the impacts on our children, and people are stepping in and trying to do something about that. And that's just a recent example, but there will be more.
Perfect. Thank you very much. We're almost at time, so I don't think we'd have time for audience questions. But I just want to ask a very quick question of you all now. In terms of you're all covering different areas, how do you see, just to kind of in a tweet, how would you collaborate with each other? What do you need from each other in order to advance the field?
I can go first. I think it's all about responsible innovation and making sure it's addressing bias and delivery at the same time. Patient first.
Perfect. Malik?
Patient first, importantly, but also this cannot be done within one healthcare entity. This is going to be really an ecosystem play. Those are kind of initiatives that cannot be done in a lab, like the idea of doing it in a small group. That's not. So I think collaborating and making sure that we're contributing all together, and this is an ecosystem play, is very important.
Perfect.
Careful monitoring, but also be mindful that there are still people in Georgia, for one, but the United States, that lack broadband access. So all this wonderful AI may not be accessible to everyone. And so when we think about this, not only do we expand technology, we need to also be sure that we're expanding access.
Yeah. Perfect. Well, thank you all very much for your input. Really great panel. And I think round of applause for all the panelists.
Thank you, David. Thanks.